All right, so we're going to look at the mitral inflow because these are the parameters that we look at when we talking about diastolic function and diastolic dysfunction. We're going to look at the mitral annular velocity, pulmonary vein flow, diastolic dysfunction, and the grading of diastolic dysfunction. We're going to talk a little bit about the left atrial volume and color flow M mode flow propagation. Some of this we discuss in the Doppler session, so you should be familiar with it somewhat. All right. So when we talk about diastolic function, it is the period of the cardiac cycle when the heart is being filled with blood. Remember, systole is when the heart contracts and pumps blood out of it. Diastole is when the heart fills with blood. So we're going to look at what diastolic function comprise of, and then if something goes wrong in the diastolic period, how it affects the overall heart. So we have a systolic function and a diastolic function. The diastolic function is just the portion of the cardiac cycle when the heart is being filled with blood. All right. Now, this is the Wiggers diagram. It looks complicated, but it's not really. Let's start from the bottom. The bottom shows what we call a phonocardiogram. So anything as phono, it means listen, what you hear. So if we use our stethoscope and we hear the first arch sound, the first arch sound is when the mitral and the tricuspid valve close. You can only hear when the valves close. So when the mitral and the tricuspid valve close, you hear a sound. And we call that the first heart sound. The second heart sound is when the aortic and the pulmonic valve close. Remember, you can only hear when the valves close. So the first heart sound is when the mitral valve close, the mitral and tricuspid. Second heart sound is when the aortic and the pulmonic valve close, and then you start all over again. There's a third arch sound. We'll discuss a little bit about that, and then there's a fourth arch sound, and then you start with the first arch sound and then the second heart sound again. But try and understand. So when remember what we said, that when the first arch sound is due to closure of the mitral and the tricuspid valve. So those valves gonna close at the end of diastole, right? And then when the aortic and the pulmonic valve close, that's tells you that is the end of systole. So between the closure of the mitral valve and the closure of the aortic valve, that period is systole. Just think about it a little bit. That is systole. Because remember, the mitral valve is going to close at the end of diastole. At the end of diastole, you're coming into systole. And when the aortic valve closes, that's the end of systole. So the period from S1 to S2 is systole. And then the period from S2 to S1 is diastole. The period from S1 to S2 is systole. Everybody understand that?
Yes.
If you don't understand it, I can go over it again. Okay?
Yeah.
So
Can you go over
remember.
it again?
Okay, so S1 is the closure of the mitral and the tricuspid valve. Okay? S1 is the closure of the mitral and the tricuspid valve. S2 is the closure of the aortic and the pulmonic valve. So the period between S1 and S2, period between S1 and S2 is systole. Because the cycle that is between mitral valve closing and the aortic valve closing, that is systole. And the period between, now S2, remember S2 is the closure of the aortic and the pulmonic valve. And the period of time between the closure of the aortic and then the closure of the mitral and tricuspid, that is diastole. So S1, whenever they mention S1, is the closure of the mitral and the tricuspid valve. Whenever you see S2, is the closure of the aortic and the pulmonic valve. So if you were to measure that time interval between S1 and S2, it's systole, that's when the heart contracts. And the time interval between S2 and S1, okay, that's diastole, that's when the heart fills, okay? If you look on top of that, that's the EKG or the ECG, okay? Remember, I always tell you, systole is from the beginning of the QRS to the end of the T wave, and that corresponds to the phonocardiogram. When you listen, so it corresponds. Systole is from the beginning of the QRS to the end of the T wave, and then diastole is from the end of the T wave to the beginning of the QRS. So it matches up. If you look, the curve above that is the ventricular volume. So remember now, when in systole, the ventricle is going to contract to empty the blood. So at the end of diastole, it is filled with blood. Then you can see that the volume decrease in systole because the heart is now pumping the blood out. The volume decrease. Okay, and then if you look on top of that, you have the atrial pressure curve and the ventricular pressure curve. Okay? All right, let's analyze that. In systole, when the ventricle contracts, the pressure is going to increase. The pressure is building up. The pressure is building up. So that pressure increase because the heart is now contracting. And in diastole, the pressure goes down because you already contract and it's now filling. It's going to fill with blood. Okay? So this is the ventricular pressure curve. The aortic pressure curve is above that. And with the aortic pressure curve, you can see the systolic pressure is the same as the ventricular systolic pressure. The diastolic pressure in the aorta is higher. And that is why, when you talk about a blood pressure, which is really the aortic pressure, it is like 120 over 80. It's never as low as the ventricular pressure. So that is the difference between the aortic pressure and the ventricular pressure. So that is what we call the Wiggers diagram. We just put everything together. You can just look over it and go over it. It is self-explanatory. I mean, the bottom, we have the phonocardiogram, what you hear, as we mentioned before. S1 is due to closure of the mitral and the tricuspid valve. S2 is closure of the aortic and the pulmonic valve. The period between S1 and S2 is systole. The period between S2 and S1 is diastole, and that matches up with the ECG on top. Systole is from the beginning of the QRS to the end of the T wave. Diastole is from the end of the T wave to the beginning of the QRS. And then the ventricular volume. In diastole, the heart fills with blood, so you expect the volume to be highest. When the heart contracts in systole, the volume decrease. That's what you expect. And then the pressure is going to go in the opposite direction. When the ventricle is contracting, the pressure is going to be highest. And then in diastole, the ventricle is now being filled with blood. And you go over the same process. The aorta, it has the same systolic pressure, but the diastolic pressure is higher. Okay, so that's a Wiggers diagram. We'll put everything together. Now, so systole is when the heart contracts and pumps the blood out. Diastole is when the heart relaxes and fills with blood. Let's look at, remember in your physiology session, we talk about the mitral inflow. Uh, the mitral valve opens in diastole, if you remember. The mitral valve opens in diastole, and the first portion of diastole is what we call the IVRT. The IVRT. You remember that? So when the mitral valve, okay, all right. So let's look at systole. Let's look at the left ventricle in particular. When the left ventricle contracts and pumps the blood out of the aorta, at the end of systole, that aortic valve closes. The mitral valve is still closed because it has not opened as yet. It takes a little time before the mitral valve opens. So it's not as the aortic valve closed, the mitral valve is going to open. There's a gap in time. That period from the aortic valve closure to the mitral valve opening, that's what we call the IVRT, the isovolumic relaxation time. So it is the period between the aortic valve closure and the mitral valve opening. So that is, if you look at it, it's a period of time when all the valves are closed. So that's the time you're measuring. Okay, IVRT. So the aortic valve is closed and the mitral valve is closed just before the mitral valve opens. Okay, and that's the first portion of diastole, because systole ends with the closure of the aortic valve. Systole ends with the closure of the aortic valve. And now you're going into diastole. The heart is going to fill with blood, but it has to relax a little bit first, and then the mitral valve is going to open. So that's the IVRT. Remember, when the mitral valve opens, there is this suction of blood from the left atrium into the left ventricle, and we call that the E velocity. And that's the passive early filling of the left ventricle. It's like a suction effect because there's this pressure difference between the left atrium and left ventricle. And I guess you have seen E velocity on your echoes that you have done. So after the E velocity, then there's this period we call diastasis. And that is the period between the early passive filling and the late active filling. So in diastasis, the pressure sort of equalize in the left atrium and left ventricle. So nothing, the blood is not moving from the atrium to the ventricle because it's diastasis, the pressure equalizes. Then after that, the atrium contracts and pumps blood into the ventricle. And we get what we call the A velocity. So that the A velocity is the active late filling of the left ventricle due to atrial contraction. So when we break down diastole, diastole starts with when the aortic valve closes, just before the mitral valve opens, we have the IVRT. Then when the mitral valve opens, there's a suction of blood from the left atrium into the left ventricle. We call that the E velocity. Then after the E velocity, you have diastasis because of the equalization of pressure in the left atrium and left ventricle. There is no flow. And then after the diastasis period, the atrium contracts and pumps blood into the left ventricle, giving the A velocity. And it looks like this. Okay, so this is my diagram. Okay, so this is your 4, or if you want to call it the 5 chamber on the left. Okay, you have the left ventricle, you have the left atrium, and then on the right side, you have the right atrium and the right ventricle. Okay, Remember, you put your sample volume. So this is our cursor. This is the cursor right here. And you put your sample volume at the tip of the mitral leaflet. And you get something looking like this. So this first envelope is your left ventricular outflow tract envelope. Okay. And so the aortic valve opens there. And then at the end of systole, the aortic valve closes. Now you have the IVRT, which is the period between the aortic valve closing and just before the mitral valve opens. So all the valves are closed. Okay, so the IVRT is this period from the aortic valve closure to just when the mitral valve opens. When the mitral valve opens, blood is sucked in from the left atrium into the left ventricle, and you get your E velocity. Diastasis is a period when there is no flow because the pressure in the left atrium equals the pressure in the left ventricle. So there's no pressure difference, so there's no flow. Then the atrium contracts. The atrium contracts now and pumps blood from the left atrium into the left ventricle. At the end of that, the mitral valve closes. That ends diastole. But just before systole begins, well, systole begins when the mitral valve closes. Systole begins when the mitral valve closes. But the period of time between mitral valve closure and the aortic valve opening is called the IVCT. So the mitral valve closes here, and then the aortic valve opens right there. That's what we call the IVCT, isovolumic contraction time. So that's in systole though. So diastole comprise of the IVRT, E velocity, diastasis, and the A velocity. That is the diastolic period. Any question? Do you guys want me to go over this?
No, I think I get it.
Okay, good. All right. So, and this is what it looks like. So when you do your actual echo, you have your two-dimensional image on top, okay? And you have your cursor sample volume. It's at the tip of the mitral leaflet, and you just press pulse wave Doppler. Remember, the mitral inflow is pulse wave Doppler. You have to remember that. And then you have your ECG on top. Remember, systole is from the QRS to the T wave, and then diastole is from the end of the T wave to the QRS. So this is our diastolic, sorry, this is our mitral inflow right here, the diastolic period right here. Remember what we said, the IVRT. So systole is from the beginning of the QRS and the end of the T wave. So if you can see the outline of the left ventricular flow tract envelope, it's right here, and it ends, it's not clear, but it ends right there. And then we have our E velocity here, and so it starts here. So the mitral valve opens. So the IVRT would be this period from when the aortic valve closes to when the mitral valve opens at the E velocity. So this is the IVRT. Then the E velocity is the suction of blood from the left atrium into the left ventricle. Diastasis, it's very short, but there's a diastasis there between the E and the A velocity. Then the A velocity when the atrium contracts. Okay? And then between the A velocity and when the aortic valve opens at the IVCT. So your E velocity, your A velocity, and we're going to talk about deceleration time. Deceleration time, which is basically the time from peak E to the baseline. That's basically what it is. That is the time from the peak of the E velocity to the baseline. Okay? Um, so, so we have our E velocity or A velocity. The IVRT is right inside there. Isovolumic relaxation time or period. Okay? So you have to know the definition of the E velocity, deceleration time, A velocity, IVRT. And you have to also know what's the normal numbers. Okay? So those uh parameters make up the diastolic period of the left ventricle. Okay? Let's go back here. So the normal deceleration time is usually less than 250 milliseconds. So the normal deceleration time is usually less than 250 milliseconds. And the normal IVRT is usually between 60 and 90 milliseconds. And in a normal individual, the E velocity is usually greater than the A velocity. So in a normal individual, the E velocity is greater than the A velocity. The deceleration time is usually less than 250 milliseconds, and the IVRT is usually between 60 and 90 milliseconds. All right, so we had mentioned a little about tissue Doppler imaging, and as mentioned before, tissue Doppler imaging is just looking at the movement of the tissue. That's basically what it is. So tissue Doppler imaging is just looking at the movement of the tissue, and we use the velocity. We use velocity to describe the movement of the tissue. The difference is, and tissue Doppler imaging is a pulse wave Doppler. The only difference is that the velocity is very small, and we describe it in terms of centimeters per second. Remember, when we look at the mitral inflow, we talk about E velocity, which is meters per second. But when we do tissue Doppler imaging, it's centimeters per second. Still pulse wave Doppler, though. Still pulse wave Doppler. So with tissue Doppler imaging, this is obtained by placing the sample volume at the medial mitral annulus and the lateral mitral annulus. Okay, and we're going to show you what that looks like. So you place the sample volume at the medial and the lateral mitral annulus. You want to see how much that tissue moves, the speed of it. But remember, it has a direction, so we talk about velocity as opposed to speed. And it's a pulse wave Doppler. And this is what it looks like. So your two-dimensional echo is on top. Okay, your cursor is here, and we put the sample volume. You put that the medial mitral annulus, and you also put that the lateral mitral annulus, and you press. The different machines will have different ways of doing it, but if you have tissue Doppler imaging (TDI), you press that, and you get your tissue Doppler imaging on the bottom. All right, so let's analyze it again. Your cursor is right there. In systole, the annulus moves upward, so it moves towards the cursor. So you get a S prime, okay? S prime, because the tissue moves upwards. Remember Doppler, if the movement is towards the transducer, it's going to be above the baseline. And then in diastole, the annulus moves downward. It moves away from the transducer. So we get your E prime and your A prime. Okay? So you have the S prime wave, E prime, A prime, S prime, E prime, A prime. That is tissue Doppler imaging. It is a pulse wave Doppler, but we measure in terms of centimeters per second. So the S prime wave is the systolic annulus velocity. So it moves upwards, it moves towards the transducer. The E prime wave is the early diastolic annulus velocity. So it's the early diastolic annulus velocity. And the A prime is the late diastolic annulus velocity. And we show you what those look like. Important point, E prime reflects reflects relaxation of the myocardium. So remember that. E prime reflects relaxation of the myocardium. It gives you information about myocardial relaxation. And it is reduced in patients with impaired myocardial relaxation. So if the patient have a problem with the heart muscle relaxing, the E prime is going to be reduced. And when we talk about reduced, it's usually less than 8 centimeters per second. So if it is reduced, it's usually less than 8 centimeters per second. The E prime is usually more than 10. In a normal individual, it's usually more than 10 centimeters per second. The lateral E prime is usually larger than the medial E prime. That's another important point. The lateral E prime is usually larger than the medial E prime. You get a decrease in E prime, where a decrease in E prime is one of the earliest markers of diastolic dysfunction. So if the patient has a problem with diastole, the E prime is going to be reduced. The patient cannot have diastolic dysfunction and a normal E prime. Okay? Very important point. The patient cannot have diastolic dysfunction and a normal E prime. The E prime has to be less than 8 centimeters per second. Okay. We also use the ratio of E to E prime to assess left atrial pressure or LV filling pressures. One of the if you just sort of think a little bit, if the heart is not functioning well for whatever reason, reduced systolic function or diastolic dysfunction, if the heart is not pumping very well, one of the first thing that's going to happen, or the first thing that's going to happen, is the pressure inside the left ventricle is going to increase. The pressure in the left ventricle is going to increase if it's not working well. And you can assess that pressure. You can assess that increase in pressure by looking at what we call the EE prime ratio. So you remember the mitral inflow, you measure that E velocity, and then with your tissue Doppler imaging, you measure your E prime. The ratio of your E to E prime, if it's more than 15, then it suggests elevated left ventricular filling pressures. Okay, so that means the heart is not functioning properly, because the first thing that's going to happen when the heart is not pumping well, the pressure in the left ventricle and hence the pressure in the left atrium is going to go up. So EE prime will give you a good indication of the left ventricular filling pressures. And if it's more than 15, then it suggests it's elevated. Okay? We usually measure it when we, in the intensive care unit or in the cath lab, we usually put catheters inside the heart and we can measure it. And when we call it the wedge pressure, when the wedge, that's one of the terms we use. the wedge pressure. And when we put catheters inside the heart and we measure that wedge pressure, if it's more than 20 millimeters mercury, then it suggests the pressure in the left ventricle is elevated. Okay? Elevated left ventricle end-diastolic pressure. So remember, the EE prime ratio greater than 15 suggests that the pressure in the left ventricle, we're talking about elevated left ventricle filling pressures. Also, if the E to E prime ratio is less than 8, then that correlates with a normal left ventricular pressure, filling pressure. Okay, so that's important. But remember, the EE prime ratio is crucial. Okay, you cannot have diastolic dysfunction and a normal E prime. The E prime is usually less than 8 centimeters per second if it's if you have diastolic dysfunction. All right, so we did talk a little bit about the pulmonary vein flow. We use that also to assess diastolic function. So remember your two-dimensional images on top, your 2D images on top, and remember from your anatomy, okay, the pulmonary veins are down here. Remember, the pulmonary veins drain into the left atrium, and you have the right lower pulmonary vein there. The left lower is right over here. Remember, it's a pulse wave Doppler. You put your cursor, you line up your cursor here, and the sample volume is about 1 centimeter into the vein, and you just turn your Doppler on. Your ECG is on top, okay? So you get a systolic component, you get a diastolic component, and an atrial reversal. So you get a systolic component, a diastolic component, and an atrial reversal. So your ECG is on top. So ECG is on top. Remember, systole is from the beginning of the QRS to the end of the T wave. So this is the systolic component. Diastole is from the end of the T wave to the beginning of the QRS. So we have a diastolic component. And you also have what we call the atrial reversal, which is below. Let's analyze what's going on here. Remember, blood flows from the pulmonary veins into the left atrium. Your cursor is right there. Your probe, your transducer is right here. So the blood is flowing towards the transducer. So it's above the baseline. So the systolic component is above the baseline. So in systole, that's ventricular systole, blood is flowing from the pulmonary vein into the left atrium. In diastole, blood is still flowing from the pulmonary vein into the left atrium. But when the atrium contracts, it pushed the blood in the opposite direction. Now the blood is moving away from the transducer, hence it's below the baseline. So you get a systolic component which is above, you get a diastolic component which is also above, but the atrial reversal is because the atrium contracts and push blood in the opposite direction. So that is your pulmonary vein flow, pulmonary vein velocity. A normal pulmonary vein flow is the systolic component is larger than the diastolic component. So with a normal pulmonary vein flow, systolic component is larger than the diastolic component. When you start getting diastolic dysfunction, then the opposite occurs. The systolic component gets less than the diastolic component. Okay? So the greater the stage of the diastolic dysfunction, then the systolic components get less and less. Okay? So if you're assessing diastolic function or dysfunction in a patient, and the S or the systolic component is much greater than diastolic component, then it's not a very uh, it's an early stage of diastolic dysfunction. If the systolic component is very, very small compared to the diastolic component, then that's a later stage or a worsening of diastolic function. All right, so this is your atrial reversal. Try to show it there. All right, so the S is the systolic wave or systolic component. D, diastolic wave, diastolic component. Yeah, that's atrial reversal. So we say as the left atrial pressure increases, the systolic forward flow peak velocity decreases, and that's the same thing we're saying. As the diastolic dysfunction get more severe, the systolic component decreases. Okay, as the left atrial pressure, because as the diastolic dysfunction gets worse, the left atrial pressure and left ventricular filling pressure also increases. Okay, remember when the heart fails, one of the first thing that happens is the pressure in the left ventricle increase. All right. It is very important when someone said that they have heart failure, you know, it is customary for everybody to think that the heart muscle is weak. So it is customary for everybody to think that the patient have systolic dysfunction. But diastolic heart failure accounts for about 50% of heart failure cases, and its prevalence increases with age. So diastolic heart failure accounts for half of patients with heart failure. But it's just customary when someone says they have heart failure, you think that the systolic function is reduced and they probably have an ejection fraction of 20 or 30%, which is not the case. 50% of heart failure patients have diastolic dysfunction. And as one gets older, it's more than 50%. So the grading of diastolic dysfunction can help in the management strategies, how you treat the patient. So if you can grade it, then you can affect management by tailoring the treatment uh, to the level of diastolic dysfunction. So the higher grading suggests worsening of left atrial pressure and the left ventricular filling pressure, as we said. So we have a 4 grading system. We have a grade 1. Well, you have normal, so you have what normal is supposed to look like. Then you have grade 1 diastolic dysfunction, grade 2, grade 3, and grade 4. So it's important for you to grade it. So when a patient comes to the echo lab and I am reporting on diastolic dysfunction, you have to put a grade, right? So grade 1 is not as bad as grade 2, which is not as bad as grade 3 and 4. All right. So when we talk, so let's go over the normal. What's normal? Okay. So what's normal? Remember, in a normal individual, the E is greater than the A. Remember, the deceleration time is more than 250 milliseconds, and the IVRT is between 60 and 90 milliseconds. We discussed that at the beginning of the lecture. So normal E is greater than the A. Deceleration time is usually less than 250 milliseconds. And the IVRT is between 60 and 90 milliseconds. So when we talk about a grade 1 diastolic dysfunction, we talk about abnormal relaxation. So the heart is not relaxing properly to fill with blood. So that's a grade 1 diastolic dysfunction. And the E to A ratio is usually less than 0.8. You don't have to measure it closely. If the E is smaller than the A, then you're thinking in terms of a grade 1. But you need more things than that. Okay? For for uh, for grade 1, the deceleration time is usually more than 200 milliseconds, and the IVRT is usually more than or equal to 100 milliseconds. Okay? So those are some of the things that usually will tip you off that there is grade 1 diastolic dysfunction. Remember, you cannot have diastolic dysfunction unless the E prime is less than 8 centimeters per second. So if you have those things up front, at the top, if you have these and your E prime is more than 8 centimeters per second, the patient does not have diastolic dysfunction. The patient does not have diastolic dysfunction. The E prime have to be less than 8 centimeters per second. Okay? And then your E prime ratio, remember, or EE prime ratio, tell us about the filling pressures. If your EE prime ratio is less than 8, then we talk about a normal filling pressure. Okay? And then when we look at our pulmonary vein flow, the pulmonary venous flow predominant systolic flow. So the systolic component is greater than the diastolic component. So these are the things that is necessary for a type 1 or a grade 1 diastolic dysfunction. Okay? Your E is usually less than the A. Deceleration time is prolonged, more than 200 milliseconds. IVRT is usually prolonged, more than 100 milliseconds. And the E prime have to be less than 8 centimeters per second. You cannot have diastolic dysfunction with an E prime which is more than 8 centimeters per second. And the filling pressures is usually normal. So your EE prime is usually less than 8. And you have systolic predominance in your pulmonary vein flow. Okay, so that is your grade 1. And you have to know what your grade 1 looks like. Okay. All right. So that's grade 1. And so remember, when the patient have a problem with diastolic dysfunction, grade 1, it's a problem with relaxation. They have a problem with relaxation. The heart is not relaxing properly to fill with blood. And this is what you actually get. So remember, your 2D is on top, and then you have the Doppler below. So this is a mitral inflow that we've been talking about, mitral inflow. So it's diastolic. It's a diastolic period. So you have your E velocity, you have the A velocity, okay, and you do your deceleration time. Deceleration time is from peak E to baseline. You can see that the E is smaller than the A. E is smaller than the A, so that's one tip off. And if you measure your deceleration time and it's more than 200 milliseconds, that's another tip off. This is the pulmonary vein flow. Okay, 4-chamber, you stick the cursor right in the pulmonary vein and you get your systolic component, diastolic component, and the atrial reversal. If the systolic component in the pulmonary vein flow is greater than the diastolic component, that's also consistent. But the key is your tissue Doppler. The key is the tissue Doppler. Okay, you probably can't see clearly, but the cursor is on the medial mitral annulus, and you get your tissue Doppler. This is the S prime, this is the E prime, and this is the A prime. So your E prime have to be less than 8 centimeters per second for there to be diastolic dysfunction. And then this would be a type 1. It would be a grade 1. Grade 1 because the E is smaller than the A. Pulmonary vein flow, systolic predominance, and with the tissue Doppler imaging, your E prime is less than 8 centimeters per second. Grade 2, so grade 2 is sort of crucial. So let's see if we can understand grade 2 thoroughly. Um, with grade 2 diastolic dysfunction, we call it pseudonormal. We call it pseudonormal. And the reason why we call it pseudonormal is because the E is usually greater than the A, which looks normal. So with pseudonormal, the E, when we do our mitral inflow, the E is greater than the A, so it looks normal. And a lot of people would think it's normal. But the key is when you do your tissue Doppler imaging, the E prime, the medial E prime is less than 8 centimeters per second. It's not normal to have an E prime which is less than 8 centimeters per second. It is not normal. So if the E prime is less than 8 centimeters per second, the patient have diastolic dysfunction. So with grade 2 or pseudonormal, the E is usually greater than the A. The E prime, of course, have to be less than 8 centimeters per second. No, it's a worsened stage or a higher stage in your diastolic dysfunction. So the filling pressures now gonna start to increase. And when you look at your pulmonary vein flow, it's now diastolic predominance. So the systolic component will be less than the diastolic component with your pulmonary vein flow. And because the pressure is now increasing in the left ventricle, the left atrium, the volume of the left atrium is going to increase. So the size of the left atrium is going to increase because there's now more pressure in the left ventricle. All right. So grade 2 is what we call pseudonormal. Okay. It's still a problem with relaxation. So it's an abnormal relaxation. And when you do your actual Doppler study, it looks like this. So your mitral inflow, two-dimensional echo is on top. Your cursor is there. The sample volume is at the tip of the mitral leaflet. So in diastole, that's what we're looking at. You have your E velocity. You have your A velocity. Okay. You see the E is bigger than the A. So there's a tendency to say quickly that this is normal. But let's look at some more parameters. If we look at our pulmonary vein flow in systole, which is from the beginning of the QRS to the end of the T wave, we have our systolic component, then we have our diastolic component, and our atrial reversal. You see the systolic component is less than the diastolic component. So right away you think, it's just not really normal. But when you move to your tissue Doppler now, tissue Doppler, at the medial mitral annulus, the E prime is very small. The E prime is less than 8 centimeters per second. So this patient have diastolic dysfunction. Just by looking at the E prime, it's less than 8 centimeters per second. So the patient have diastolic dysfunction, but the E is bigger than the A, so it's pseudo-normal. And then when you look at pulmonary vein flow, you have diastolic predominance. Okay? So that's grade 2, pseudo-normal. Then we have grade 3 and 4. We have grade 3 and 4. Now, grade 3 and 4 looks the same. Okay? And this is a worse stage of diastolic dysfunction. And we call this, patient is now having a problem with filling, the restrictive filling. We call it a problem with compliance. So the first two, 1 and 2, is a problem with relaxation, and then 3 and 4 is a problem with compliance, restrictive filling. And restrictive filling have a very specific pattern. In restrictive filling, the E is usually very, very large, the A is usually tiny, and we talk about the E to A ratio, E to A ratio greater than or equal to 2. So the E is usually very, very tall, and the A is tiny. The deceleration time is usually constricted, and it's usually less than 160 milliseconds. The IVRT is also constricted, and it's usually less than or equal to 60 milliseconds. Okay? So the E to A ratio, more than 2, more than or equal to 2. You cannot have diastolic dysfunction unless your E prime is less than 8 centimeters per second. So this is key again. So the E prime is going to be less than 8 centimeters per second. And because this 3 and 4 is a worse stage of diastolic dysfunction, the pressures in the left ventricle is going to be tremendous. So when you do your E and your E prime, it's going to be more than 15, greater or equal to 15. So remember that tell you that the pressure in the left ventricle filling pressure, and left atrial pressure is very high. And not only that, but because the pressure in the left ventricle is very high, the volume, the size of the left atrium is going to be huge. So we talk about left atrial volume index. And then when you do your pulmonary vein flow, you have diastolic predominance. The diastolic component is much larger than the systolic component. So this is your grade 3 and 4 diastolic dysfunction, restrictive physiology. We call it restrictive physiology. And it looks like this, okay? So large E, small a, E to A ratios greater than or equal to 2, okay? Big E, small a. See your deceleration time, if you were to measure this from peak E to baseline, less than 160. And then if you were to measure your IVRT, it's usually less than or equal to 60 milliseconds. But your E prime have to be less than 8 centimeters per second. You cannot have diastolic dysfunction unless your E prime is less than 8 centimeters per second. And when you do your E prime ratio, it's usually greater than 15, suggesting elevated filling pressures. All right. Just some additional points. We talk about a Valsalva maneuver. So when you do a Valsalva maneuver, you sort of bear down like you're having a bowel movement. And what that does, it's a forceful expiration against a closed nose and mouth. So just a strain, you strain. And there are usually 4 phases, but phase 2, what happened during phase 2, when we talk about the preload, the amount of blood going to the heart is decreased. The amount of blood going to the heart when you bear down decrease, and as a result, it also decreases the amount of blood leaving the heart. So when you strain, that is basically what's happening. The amount of blood going to the heart from the inferior and superior vena cava is reduced. So the amount of blood leaving the heart through the aorta is also going to be reduced. So someone with pseudonormal, so remember what we said, with pseudonormal, it looks normal, okay? And if you didn't do your tissue Doppler imaging, you might never know. But if they do the Valsalva maneuver and you measure it, it will revert back to your grade. You'll get a very tiny E and a large A. Okay, so the Valsalva maneuver can unmask your pseudonormal individual. So pseudonormal, which says the grade 2 diastolic dysfunction, the mitral inflow changes during the Valsalva maneuver to impaired relaxation. That is, the E velocity decreases, deceleration time usually is unchanged, and the ratio decreases. So basically, the Valsalva maneuver can unmask the grade 2, the pseudonormal. All right. Um, so as mentioned before, with the phase 2 of the Valsalva maneuver, there's a decrease in the blood flow to the heart. So you're going to get a decrease in the E and the A velocity, but the E is going to decrease even more if the patient has a pseudonormal. So you can unmask the pseudonormal with the Valsalva maneuver. All right, so we talk about left atrial volume. The worse the stage of the diastolic dysfunction, then the volume in the left atrium is going to get larger and larger because the pressure in the left ventricle is going to get higher and higher. It's going to put more strain on the left atrium. So if you to measure the left atrial volume, we're just going to go over this real quick. I'm not going to spend a lot of time on it, but it's customary when we measure in the left atrium. If you remember, in the parasternal long axis, we just measure linear, from one wall to the next wall. If it's more than 4 centimeters, then it's enlarged. But there's a push ahead now to measure left atrial volume, and this is done. You do your apical 4-chamber view and your apical 2-chamber view, and it's what we call it's an area length method. Area length method. You measure the area of the left atrium and you measure the length, and I'm going to show you what to do with that. So so you obtain your apical 4 and your 2-chamber views. The left atrial volume and pressure increases with worsening diastolic dysfunction. Remember, the greater the pressure in the left ventricle, it's going to put more pressure on the left atrium. So the volume is going to increase and the pressure is going to increase. So this is our 4-chamber view. You just measure the area of the left atrium and you measure the length. In the 2-chamber view, the same thing. You measure the area and you measure the length. And so that's the area. So we call one area 1 and the other one is area 2, and you measure the length. So this is the formula that we use. So it's the area inside the area in the 2-chamber view times the area in the 4-chamber view, and we're going to divide by the shortest length. So remember, the length was from the base to the top of the atrium, and then from the base. So these lengths are going to be different, okay? And the area is going to be different. So it is the area in the 2 times the area in the 4, and we're going to divide by the shortest length, and we're going to multiply it by 0.85. The computer does this for you in the machine, but this is what it's doing, okay? And that's how you get the left atrial volume, which is a much more accurate assessment of left atrial size. We're not going to talk about the color M mode because we don't use it anymore, but it's an M mode scan line and it's placed through the center of the LV from the valve, mitral valve to the apex, and the normal flow propagation is usually greater than 50 centimeters per second. So we really don't use it anymore. This is what it looks like. You can look it over if you wanna. Okay. So that is diastolic function and dysfunction in a nutshell. Go over the lecture multiple times and